Patient and Public Engagement Lunchtime Learning Series, but I'd also like to welcome everyone who's joining us live via webcast. And just to let you know, today's topic is going to be about budgeting for patient and public engagement and health research, an exciting topic that we get lots of questions about here at the Georgian Fahey Center for Healthcare Innovation. To start off with, we'd like to make some acknowledgements that we are gathered here today on Treaty 1 land, home of the Anishinaabe, Cree, Oji Cree, Dakota, and Dene peoples, and homeland of the Métis Nation. And in coming together today, we respect the treaties that were made on these territories. We acknowledge the harms of mistakes of the past. We recognize the ongoing present-day colonial violence that is faced by Indigenous people within healthcare systems, education, social justice, and child welfare and government systems. And we dedicate ourselves to moving forward in partnership in the spirit of reconciliation and collaboration. And again, for patient and public engagement, some Indigenous research methodologies, of course, are at the forefront, and Indigenous scholars and researchers, you should be following as well. Today's agenda, I'm very, very, very quickly going to go through, go through what is patient-oriented research, the SCORE definition, and then what is patient engagement. Then we're going to talk a little bit about barriers to engagement. We're going to look at budget considerations, and then we're going to introduce you to an online tool we have around budgeting, and then we'll have some questions, and we'll let you know what the next session is going to be about. Oh, disclosures. I am employed by the Georgian Fahey Center for Healthcare Innovation. I am the Patient Public Engagement Lead. So oftentimes we just want to start out with so that we're all on the same page about what is patient-oriented research. And the Georgian Fahey Center for Healthcare Innovation is part of a national initiative called SCORE, which is a strategy for patient-oriented research. And the definition of patient-oriented research is kind of like a five-prong approach. It's a continuum of research that incorporates all of these elements. So it engages patients as partners. It focuses on patient-identified priorities. It improves patient outcomes. It's conducted by multidisciplinary teams in partnership with relevant stakeholders, and it aims to apply the knowledge generated to improve healthcare systems and policy. And it's so, if you notice, again, I capitalize the and I underline it because it incorporates all five of these elements. And when we're talking about patient engagement in health research, the Strategy for Patient-Oriented Research, the Canadian Institutes for Health Research, define it as the meaningful and active involvement of patients in the governance of research. So that means having people with lived experience on your steering committee, on your research teams, throughout the research process. The priority setting of research. So as we said before, we're having people with lived experience identify the research priority that's going to be looked at. The conducting of research, so having people with lived experience actually actively involved in conducting the research. And then the knowledge translation of research, so meaning the dissemination of the research findings and the implementation of the research findings. Now, when we talk about budgeting, one of the important things I always think to start with is actually addressing and thinking about what are some of the barriers that people with lived experience might face when they are interested in engaging, so that we can then build a budget that incorporates and addresses all of these barriers. So the first one is more of a larger one that you wouldn't have in your budget, but one of the barriers to engagement is what people are actually being asked to engage about. So we know that abstract healthcare system kind of research questions around health strategies and so on, as opposed to direct kind of focused healthcare services are around an actual health issue may not be directly relevant to people with lived experience. And so if you have to be actively trained in order to engage in a health research project, this means there's time that's required, and that time may be a barrier for people with lived experience. So it may take a low priority for some people who have more pressing issues in their lives, right? Especially if they're living with individual chronic health issues and so on. So thinking about even what you're engaging people about will help you identify what kind of participatory approach you're going to use, because people will be differently motivated to engage and will face different types. There will be different barriers for them in that way. Learning about the opportunity. So this is a big one. A lot of times with recruitment, we might just use one method, right? We'll engage healthcare professionals who will then identify people with lived experience that we can engage. Well, what happens is there are some people who may not have the same sort of access to healthcare, so you might not be able to engage people simply through healthcare service providers. So thinking about the different ways in which you can recruit people who might be interested is really important. And of course, that takes money as well, because maybe it's a combination of putting an ad in a local newspaper, or having a little blip on a radio show that the local community listens to. So thinking about kind of multi-pronged approaches if you want to engage diverse perspectives along the way. Language barrier is another one. Oftentimes in our recruitment materials, if we only use English, we don't have any translation, that means you're really only engaging people whose first language is English. So thinking about how you might be able to engage people where English is not the first language is really important as well, because what may happen is that you have a very kind of focused group of people that you're engaging, and you're neglecting a lot of other voices. Cognitive function, there's a lot of presumptions about, especially with health researchers and even healthcare providers, may not necessarily seek input from people who have lower cognitive function, but there are amazing examples, and we have some PE award winners right now who are working in the area of engaging people with intellectual disabilities, engaging people along entire spectrums. And all it means is that you have to choose a different type of participatory approach in order to engage people. It doesn't mean that people can't be engaged. The time and energy commitment is definitely another piece of the puzzle, because you've got to think about what you're asking people to commit to. Because people are willing to commit a certain amount of time and energy if they feel that there's value to their involvement. And that all depends on the engagement method that you choose. We've seen in some reviews that single events a lot of times have deeper levels of engagement going on, because it's a one-time commitment. People can come and help co-develop. Whereas if you have ongoing advisory groups, there is a lot of times going to be a drop-off, because people have life factors, healthcare factors that may not enable them to engage for long periods of time. So think about what ways might be the best. And sometimes it means having different opportunities. So some people may be able to attend a one-time event. Other people might want to be engaged for a longer length of time. So thinking about, you might have multiple different opportunities and budgeting for those accordingly. It's also really important to think about how people feel about their own capacity and skills to participate. So there are certain people who may feel less likely to see themselves as having something to contribute, especially if it's something complex around policy or the healthcare systems, or because they've had past negative experiences, they've encountered institutional discrimination, those types of things, or internalized biases. So understanding all of these aspects and how people how people may feel that they don't have that ability, and being able to develop participatory approaches that are going to meet people where they're at versus making people have to train or feel like they don't have enough skills to be able to engage. We also know previous negative experiences. If you've ever been part of our previous sessions around trauma-informed engagement, you'll know that people who have had some lived experience in healthcare systems that have been negative, traumatic, may see health researchers and even facilitators at an engagement event as representing that type of institution and maybe more reluctant than to engage. So understanding that you may have to build in special supports in order to allow people to be engaged in a trauma-informed way. Now, once you've actually have people who are interested in getting engaged, then come some of the barriers to actually getting there. So child care responsibilities. People may have children, grandchildren, nieces, nephews, people that they are responsible for looking after. So building your budget to include these types of things is really important. Oops. There may also be, and so this is a lot of times forgotten, there are people who live in the sandwich generation who are looking after young children, but may also be looking after elderly parents. They may have older adult children who require respite care. So making sure that you have these pieces in place so that people can actively engage is really important. Thinking about other barriers, people who may have inflexible employment schedules, these types of things, there's some limitations in finding ways to reach people in this way as well as important. Access to transportation, of course, this is something that you are going to have to think about when you're budgeting, and this is a big one. And access to travel insurance, we've actually added this one in because we've had this experience. People with lived experience don't always have travel insurance. And if you're expecting them to travel somewhere to engage, making sure ahead of time that you can get some travel insurance for them through your institution is really important. And then we understand if you're engaging over a long period of time, there are multiple things that may happen to people with lived experience that impacts and creates a barrier to engagement. So unstable housing is one. It's a priority, it's a necessity, it's something that will come before engagement. Unpredictable schedules, people who work shift work, those types of things may be difficult. Food insecurity. You're living in a food insecure house where you're having to sacrifice your meal to feed your children, then you're probably not going to have a lot of energy to go and engage, and these things might get in the way. Basic survival, these are things, and it's important to understand that different people experience these barriers to different degrees at different times. So we have to understand how these may impact the way in which we engage. And sometimes it's about being flexible. If people can't make the meeting, are there other ways that you can engage? Is it a telephone conversation instead? How do we make sure that we shift and meet people where they're at? And also provide support if they need somebody to just listen to at times as well. We know that women are likely to experience many of these barriers because of gender prescribed roles. So if you think about things like family, children, caregiving, and those inability to leave dependents or afford alternative caregiving, respite, then you add other things like socioeconomic status, and these things start to really impact people's ability to engage. The setting of engagement, so when you're deciding on your setting, it's going to be really important to think about how people can be engaged, because some people may be physically incapable of getting to events, so people who are housebound, understanding how you're going to be able to engage those voices as well. Again, negative experiences. People have had negative experience in healthcare systems or within academic institutions, inviting them to come over and engage and have a meeting spot within a healthcare system may not be the best idea. So thinking about community-based places where people can meet as well. Power dynamics is a huge one that we always have to, and I think everybody's used to hearing about this from me, but through a variety of mechanisms, from the participatory approach that we choose, the facilitator that we choose to run an engagement activity, the way in which we do our recruitment, all of these things, power dynamics shape whether certain groups of people are going to be able to engage, how they're going to be able to engage, and how their engagement is legitimized to help actively inform health research decision making. So meaningful engagement means you actually have to address these power dynamics between patient-public partners and health researchers or healthcare providers, decision makers who are on the research team, as well as the facilitator, because there's a lot of social capital sometimes with a facilitator, and finding the right facilitator is really important, because I think many of us have had times where we've perhaps chosen a facilitator who just wasn't the right match, and things can go badly if people don't feel they can trust a facilitator to navigate these conversations. Again, where the event is held, it's important to think about rural and remote. If you're always holding events in the city and requiring people to travel, these are important things to think about. And then the participatory approach that you're actually asking people to do. So online surveys, if you don't have internet connection, these are important things. Help also having people with healthcare professionals in the room who may have treated patient partners who are there as well. If there's a relationship there, addressing it right off the bat that what people with lived experience say is not going to impact their healthcare is really important, and having that up front is very important to talk about. Those are the other ones. Sometimes there are barriers as far as patient and public partners themselves, making sure that there's the dynamics between patient-public partners is a consideration to think about as far as barriers, because this can actually influence how knowledge is generated and what information is going to be used to inform your research decision. So sometimes there are people with lived experience who have more experience engaging in research, and so they might understand the jargon and the lingo that researchers use and understand that kind of formalized language. And then there might be other people in your group who haven't engaged before. And so they might feel less knowledgeable. They might feel more intimidated to express their opinion, seeing this other person with lived experience who has more knowledge around this. So making sure that when you are engaging, that these different types of voices can be heard, and that there's space for all of these voices. There's also, when you think about healthcare, can be a very private issue for some, and so there may be times people with lived experience, if they've had different experiences than other people in the group, and it's construed differently. So talking about things like sexuality, things like substance use, people may feel not so comfortable in expressing those things. So making sure that you have different avenues for people to be able to express their opinion, even outside of the group, one-on-one, if that works better. The style of engagement. So we know, again, different participatory approaches, we want to make sure that we use the right ones. So we know there's been some evidence around participatory approaches that use deliberative processes, so citizen juries and those types of things. They may be good for certain types of decision making, but they also kind of prioritize people who are able to express themselves in a certain way, in a deliberative way, who can be quite articulate and put their point across. And so people who express themselves maybe in a more emotional way, may feel, or people who are a little bit more introverted, it may not be the best participatory approach all the time because it could prioritize certain voices, certain styles of communication over others. And then the types of evidence suggested. Again, there are different participatory methods, such as citizen juries, where you present the evidence through an expert panel where people present to the patient partners, here's all the evidence. There has been some criticism around that because then the evidence has actually been predetermined and selected before presenting it to people with lived experience. So there's questions around that and how people with lived experience can incorporate their experiential knowledge and what they perceive as evidence. That's important as well. So thinking about all of these wonderful things when you're starting to build your strategy and how that might impact on your budget and how you might address that in your budget. So budgeting, one of the big questions a lot of times is around compensation for the time, energy, and expertise of people with lived experience. Here at the Georgian Fahey Center for Healthcare Innovation, we're huge on compensating people for their time. If everyone around the research table is in some way either directly being compensated or indirectly by advancing their careers, advancing their schooling, those types of ways, people with lived experience should also be compensated for their time. There are a number of ways that you can compensate people with lived experience. There is the fixed service income. So an hourly or a daily rate is really important. I know there's been recommendations from these 4 networks to consider a minimum of $25 an hour for people's lived experience and their time. Sometimes if you're doing one-time events, perhaps an honorarium would be more appreciated for attending the meeting or the workshop. And in that case, it might have less of an impact on people's disability or people's taxes as well. There's opportunities for in-kind compensation, which can include anything that will help empower people with lived experience, partners, or help them along their journey to recovery. So think about things like tuition for a course, Word, an upgraded Word for your computer, yoga classes, something that people will feel is something that can help them along their journey. Sometimes we have patient public partners who do not want to be compensated, but would prefer to donate money to a charity of their choice. This is an opportunity as well. And then in some cases, people with lived experience will say, no, I don't want to be compensated. The biggest thing is to talk to everyone one-on-one. This is not like a group conversation that you have with a group of people with lived experience, but rather talking to people one-on-one. What would be the best way? I'd like to compensate you for your time, but what would be the best way for me to compensate you that doesn't negatively in any way impact, say, your taxes or those types of things. So having that open and honest conversation with them is so important. Yes, Sarah.
Are you suggesting that then maybe say you have 4 patients in your group that patient partners, they each may be compensated in this way? Is that what happens sometimes?
So Sarah, our wonderful guest, is bringing up a good question. So you may have 4 people on a research team who are involved who may be compensated in different ways, and that's between you and the person individually, because some people may prefer a different way of compensation over others. I think we've had teams where if it's going to impact someone negatively for their disability, they may want, we've had times where research teams where actually someone's working remotely where we've actually helped upgrade their computer or something like that, and that's the way to compensate because they're actually using that computer to do the engagement activities. So those types of things. But having those conversations, yes, having people can have choice, I guess, to the ways in which they want. It's important too to think about care attendants or caregivers, so people who may come along, who are needed to come along with people with lived experience, that they are adequately not only compensated, but thinking about accommodation, food, all of these things for people who come with experience as well, and making sure you budget for that, right? You're engaging people. Transportation, big one. So locally, thinking about whether it's bus tickets, taxi, compensating people by car mileage, also transportation from other remote or distant areas. So thinking about flights, trains, ferries, as well as luggage costs, because we now know when you fly, you have that additional cost if you want to check luggage in. One of the big things that we've learned over time is actually getting cash advances so that you're able to give people with lived experience actual money that they can pay for, say, a snack on their trip if they're taking a long bus ride, making sure that they have the money on hand so that they're not expensing it. So, and same with stuff like parking, having parking passes available right there so they don't have to expense that, because that can be a complete barrier to whether people will engage or not. Parking this. I jumped ahead. Caregiving, of course, it's really important to think about how you are going to help compensate. So if somebody with lived experience has a child or grandchild that they look after and will need care services, finding out whether it's a babysitter, whether they put them in daycare in order to engage, and how you can pay for this up front for them. And same with respite services. So if someone's looking after an older adult with a disability, understanding how you can help to pay for them to come. Interpreters and translation services. This is important. We've had many activities where we've had, I think we did one engagement where we had 5 different interpreters in a room. They're engaging. So making, first of all, making sure that you have money to pay for translation services and interpreters. Also people who have visual challenges or disabilities, making sure that there may be somebody doing American Sign Language, those types of things, when you are engaging. Assistive devices as well, so screen readers, those types of things that may need to be used in order to enable everyone at the kind of abilities to engage. Accessibility of spaces. The biggest thing is a lot of times you'll see if you're renting a space that it says that it is accessible. It's really important to go and check out the space, because sometimes what is defined as accessible may be different. And sometimes if something that's considered wheelchair accessible may not be accessible for scooters. So we've had that issue before with hotels and accommodations where it was wheelchair accessible, but it was not accessible for scooters. And so a patient partner arrives and the hotel is not accessible. So going and looking at spaces before the event is really important. Here's the accommodations piece. Check out the accommodations. Food and beverages. Food is so important to factor into your budget, because you want to make sure that people are getting healthy snacks, make sure they get meals. People who are well fed are much more open to being engaged. Printing and materials, making sure that patient partners do not pay anything out of pocket, as far as they should not be expected to print out things ahead of time. Any of those things. A lot of times our patient partners like to read hard copies of things. And so if we're engaging them and want them to inform something, we print them out and we either mail it to people or people come and get it. So we make sure that we factor into our budget all of these pieces. And think about that when you're thinking of recruitment as well, what different things you might need to recruit. That costs money. It's important to pay for elders' time. So if you have elders coming, beyond the gift of tobacco, there's also payment to pay for their time. If you're having counselors or support people there, making sure that they're all being paid and compensated, and making sure that you factor this into your budget so that you're not caught off guard. Sometimes gifts for speakers, if you have patient partners presenting, other than giving them an honorarium, which I'm hoping everyone would do, also gifts, factoring that in. If you're having a day-long workshop where you're asking people to talk. A lot of times people may feel more comfortable in having a professional facilitator. This, of course, costs money. If you're having a graphic facilitator, thinking about all of those costs up front and budgeting for them. And then also making sure you really suss out whether it's the right facilitator for your engagement activity as well, that they use common formed approaches, that they have engaged diverse perspectives, and those types of things is really important. Conferences and capacity building. A lot of times people don't build this into their patient engagement strategy, and it's really important. So thinking about some of the benefits people with lived experience might get out of engaging, and maybe it's being able to actually go to a conference or take an additional training or something, or being involved in something. So making sure that you factor in flights and hotels and everything if you're hoping to have a person with lived experience come with you to a conference or enabling them to build capacity. Now we are going to have Trish, the wonderful Trish Roche, is going to come and talk about our new online budgeting tool. Yay.
So I did put in the chat for anyone online who wants to kind of follow along a link to the budgeting tool online. I'll also show you how to get there by going to chimv.ca. And I found the easy way to get there. Not always navigate the website, but you just Google or search in our search box budgeting. We have our budgeting tools page. So we developed two options. We started with this kind of rudimentary online calculator. It was a free service, a calculator, something like this. So this is if you just want to get a really quick look at what it might cost to engage with patients. Maybe if you're just starting planning, you can enter your number of gatherings, people per gatherings. For this one, I have noticed that you do need to enter, if you're not going to use one of these categories, you need to enter a 0, otherwise you won't get a total. So you can enter, compensation per person per gathering, transportation, so you give them $5 for parking, it'll be more like 12 or 15 here. And then we can go through, and it doesn't mention all of those things that you would want to consider, but it's like I said, just a quick look. Maybe $15 per person for food, meeting space doesn't cost us anything, say $2 for printing, something along that line. You can put in some other considerations, anything we might not have had there. We don't have the paid versions, so you can't send this to yourself, but again, really quick look, and then you have actually filled everything in. It'll give you a total at the bottom. That's just a really quick one. But we also did some engagement with researchers and other stakeholders around the utility of something like this and what they need. And so we did hear from researchers about wanting to have something to put into a grant application, right? So we built a Excel tool, which is free, downloadable right here. I've just updated the most recent version. It's a living document, so if you see anything that is missing or a formula doesn't work, they should. I have checked them all. Feel free to let us know. What's nice about this is once you've entered everything, it gives you this one pager, which you can copy paste into Word or you can print out as a handy one page to attach to your grant. And I'll just go through quickly what it looks like. It covers everything Carolyn has talked about. There are some necessary preliminary questions. This is the main part of the budgeting tool. So this is the budget builder. So let's say we're going to do 5 meetings and they're going to be 2 hours each, and we're going to have 5 people per meeting. And it has these hyperlinks. So as you're going through each question, you can pop over to the compensation builder, which is another tab here. You can go back this way, or you can use the hyperlinks. This has those 3 options Carolyn was mentioning, the fixed service income, honoraria, or in kind. It also has, Sarah, you were asking about maybe some people are choosing to be compensated in different ways. So you have the option now in this worksheet to choose how many patient partners will be compensated in a certain way. So say you have somebody who doesn't want to be compensated, 3 people want fixed service income and we're going to pay them $25 an hour. And 1 person wants in kind, and let's say it's a course and it's, I don't know, $200, and that'll build you your compensation total. So once you've entered everything you want in terms of compensation for your patient partners, you can pop back over to the budget builder. So it'll show you here estimated compensation. We keep going through the questions, things like refreshments per person per meeting, $50. And in this one, you don't need to enter 0. So if there's something that doesn't apply to your situation, you can just leave it blank and it will still calculate your totals. Things like support services. We do have some hyperlinks to external resources that may be useful. Some of these are specific to Manitoba, but perhaps not. I think they should. Our recommendations are specific to Manitoba and Winnipeg, but the resources should be useful for anyone across Canada. So if you're including, say, something like an interpreter, we also have this inclusivity and accessibility worksheet. That's the 3rd tab here. And you can go through these questions if you have patient and public partners with specific needs for making sure that they can meaningfully participate, right? And you can also choose, say you have, only 2 people who require out of your 5 an interpreter, and they get $25 an hour. That might be an error there. I've caught another error here. You can also go through part 3 is meeting costs. So if the cost is for your venue, if you have any AV requirements, transcription of meetings if you're recording them, any kind of disposables. There's spots where you can enter notes. So if you want to look back and be, oh, I added this extra cost, but I can't remember what it was, have that for yourself. The worksheet itself is also locked so that you can't mistakenly edit fields outside of here. And I will update that one part that is working and upload that to you. You can go through these. Okay, I need to update this. But essentially what comes around is this total estimated cost. We also have included, what we find a lot of times is when you're engaging with patient-public partners, often things come up that are unexpected. So we do recommend a contingency budget for patient-public engagement. Say you need to have an extra meeting, you didn't get through everything you thought you were going to get through. We recommend somewhere between 10 and 20%. So you can also build that into your budget. So I think that removes my errors, which is quite embarrassing. That is our budgeting tool. Again, it's a living document, so recently created, let us know if there's anything that you find is missing, if you want to use it, if you need any help with it. Feel free to shoot us an email. Yeah, I think that's about all I have to cover for that. So hopefully that's useful. Thank you. Dr. Kiernan?
Yes. Maybe you want to stay up in case they have.
Sure, yeah.
Thank you so much, Trish, for I'll just let you keep it here. Thank you so much for introducing the budgeting tool. We thought we would open it up to questions. Anyone have a question? Yes, Jennifer.
In terms of interpretations services and finding people who might be the right fit for a public engagement service setting, do you have recommendations?
A lot of times, I think a lot of times we talk to community organizations depending on who you're thinking, or depending on which interpreter, if you're language interpreters or sign language interpreters, talking to different organizations, and a lot of times they can recommend someone that they their community as well. So it's usually best to check with different groups. We have connections with different organizations that are good at recommending. I know we engaged a new immigrant group outside of Brandon. We talked to immigrant services out in Brandon, and they were able to recommend people that they use in their organization. So it's usually good to chat with all.
Catherine, just a couple of questions around you now. Station offers the initial grant for the up and starting project.
Yes.
What's the value of that? And can you give us an example of what that grant covers? What do people typically, what are they typically able to do with the amount of that grant?
What they're doing. Okay, so the Georgian Fayette Center for Healthcare Innovation has a PE award, a grant that people can apply to twice a year. The next one's coming up in the spring. We've had 26 winners so far. So far it's been $2,000 that you apply for, and it's for the pre-plan, so it's for the priority setting, research design, and grant development phase of research. So it's engaging people with lived experience before you apply for a larger grant, because that's what we heard from health researchers and communities was where there was a lack because there weren't enough resources to be actively, meaningfully engaged. So far, what we found is some of our winners, a lot of times our winners have kind of a few events where they compensate people honorariums. We've had some people have a group of people kind of help co-develop and design the space, and they're compensated. A lot of the money goes towards compensation, goes towards the event and food, and those types of things. We've had times where people have had to, a researcher travel into a rural and remote area. It's important to be able to facilitate that as well and pay for those things. We're still having conversations. We're doing an evaluation of the first round to see whether the $2,000 was sufficient enough, or whether we might have to change a little bit and perhaps offer less, offer less awards, but a larger amount. So we've been trying to engage with people, because sometimes if you're engaging rural and remote, the cost may be more, and depending on the complexity of your engagement strategy and participatory approach, you need far more. So we're still evaluating that piece, but so far that's what we've seen, mainly with the $2,000. And you're asked to submit a budget with your application, so it gives you an idea. And the good thing is we have our review committee not only has health researchers, but also has patient partners on the review, and a lot of times they even will point out like that's not enough money in the budget for food or things like this, so they understand a lot as well. They can bring that perspective. Are there other questions? Oh, Catherine, did you?
So, and then just, I noticed when you were quickly adding up, I think you totaled $4,500, like just as an example. So how do grants respond to that then when you're putting in, submitting a grant and you're saying that you're going to earmark $5,000 for engagement? I mean, what applicants' success been with that, and what does funders come back with? Is it even an acceptable portion? I mean, some grants might ask for it, but the ones that don't, how are they responding to seeing a budget line for engagement?
I know for the CIHR SCORE grants, the larger ones that people have submitted to, they do love to see that you've actually actively budgeted more compensation for patient partners, especially that you've thought about those elements of participatory research design. Whether if it's not a patient-oriented research grant, I think it all depends on the funder. I'm sure there's certain funders that are probably much more keen to see.
No, I don't have a ton of grades outside of HR.
I think it depends on how we explain it to the grant, right? Like if this grant is where the patients will be, or the public will be the main component of it. I think that's why we kind of explain it, and then that's why the big numbers.
How much is built into
Yeah.
the project itself?
Yeah, it's like if we raise it up as this is the main component of the grant, I think it should be this kind of sorted out. And then all the funding is big on this. So
And I think including something like a contingency fund, at least with knowledge translation applications,
Yes,
it shows, you know, an understanding of the need for flexibility and, you know, knowing, making sure that what you're proposing is feasible in terms of your budgets.
Are there any online questions, Amanda?
It is coming from the K2 program. How do you suggest getting organizations on board to support different types of compensation? For example, if an accounting department states they won't be able to track compensation.
That's a good question. So the question was around getting organizations or institutions on board when it comes to different forms of compensation. And this is something I think that we definitely still can find challenging at times with different institutions, universities. We've had to, a lot of times, have conversations around why we've had to, as you can see, this is one of those things that's an ongoing challenge for us. Because even within different institutions, sometimes you can encounter different people who have different perspectives. One of the big things is I've been trying to actively, researchers a lot of times will come to me and be like, I'm being told by finance that we can't use gift cards without SIN numbers, but people don't want to be taxed. How do we work this way? And the biggest thing is people with lived experience may want to be engaged in research decision, but they may want to remain anonymous at the same time. So in that case, there's kind of a conversation around we have to engage people. There are techniques, I think, for auditing where you have a number beside the gift card, and if you're ever audited, then you can give the actual formal name. But if people want to remain anonymous but want to have a say in decision making, it's important. A lot of times, I spend a lot of time though just kind of explaining the role of the patient partner, that it's different than a participant, and so there are different ways in which we want to be able to fund people, to be able, and there's different barriers to engagement that we want to really address. So it's interesting. I think it's something that we encounter even in each province. Different institutions are still, it's a big shift in the way things are done. Seeing people with experience as partners versus participants in research studies. So there's still a lot to be learned, I think, within institutions around how we can authentically, meaningfully engage appropriately. I feel like that wasn't a good answer. I'm so sorry. A lot of it is just writing and explaining why we are compensating in this way. And the importance of having patient partners and their contribution to the health research project. Kind of going back and forth and having those conversations.
Are there any new, like, decent online platforms? Because it seems like a difficult way to engage, but such an easy gap filler for, like, engaging people in remote areas or more rural areas. But other new ones out that are focused on type of engagement?
It seems like every day we come across different online platforms. I know we have an advisory group that loves Mobilize, which is an online platform where you can post things and share ideas, but you can also get it on your phone, like it's an app. And so a lot of times they actually respond via an app versus other things. So,
And I know some of our patient partners don't actually go online and use the app. They go through their email and can respond. So if they prefer not to actually, if they find it confusing or cumbersome, they can just use their email to respond to those messages in that group. So Mobilize has worked in that way.
and it's free.
And they have the time, like, it's not engaging them at a particular point in time. It's like giving them a range of, like, if it's via email. It's almost like a message board in that way. But are you referring to things like webinar, like meetings, or I don't know?
Yeah, I think the biggest thing is talking to people about what they currently use, because I think Mobilize was one of the patient advisors was the one that came to us saying, I think this would be a good way. I know other groups have used Facebook because Facebook is the medium in which they feel most comfortable in using. So a lot of times just talking to people about what is the online tool that you feel most comfortable with, or that you have access to, and figuring out from there that whole conversation at the beginning, how do we want to Excellent. Well, next month, April 10th, we are going to have another case study. We're going to have Dr. Natalie Reidiger talk about community engagement and transformative research about a controversial food policy. Natalie was one of our Patient and Public Engagement Award winners, and she's going to talk about how she engaged community around the sugar tax. Oh, around the sugar tax. Was it the sugar tax? I think so. And she used some very innovative ways to reach communities and engage them on this subject. So I hope everyone can join us. Oh, Amanda, was there one more question?
Yes, we have a question. When you have already prepaid expenses for travel, etc., what do you do if the patient partner cancel their attendance due to
I know to that. So I think in that case, it's often similar to as if an employee has to cancel last minute. Usually, you'll have an account or whatever set up, and you can often get, your credit for flights or hotels. So I would think it's a similar process. And sometimes, same as with employees, you just have to eat some of that cost, unfortunately.
Great. Well, if you have any questions or any other things that you want us to chat about, or any suggestions about a session that you would like to see, definitely feel free to contact me anytime. Thanks so much, everyone.